Hello, I am Jan Leifman.
And I am Muskan Joshi.
Welcome. Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Hagop Kantarjian. Dr. Kantarjian is the Samsung Distinguished Leukemia Chair in Cancer Medicine. He's also a professor and chair of the Department of Leukemia at the MD Anderson Cancer Center.
In today's presentation, Dr. Kantarjian discusses different classes of leukemia and the evolution in their treatment.
Did you know that Dr. Kantarjian pioneered the use of epigenetic therapy in leukemia? He also established the world-renowned Department of Leukemia at the MD Anderson Cancer Center and has served as its department chair for over 35 years. He also led clinical studies of several FDA-approved therapies, including Clolar, Dacogen, liposomal vincristine, and ruxolitinib, along with imatinib, decitabine, nilotinib, ponatinib, bosutinib, and omecitaxine.
He truly is an inspirational leader in the field of medicine.
So let's tune in and learn from this global leader.
So to give you a simple picture of the leukemia so you can follow the talk, I'm going to divide them into the acute leukemias and the chronic leukemias. Acute leukemias were called acute because without therapy, most people died within 3 months. Chronic leukemias were called chronic because without therapy, patients lived about 2 to 3 years. And then we divide them according to the cell involved. So if it is the granulocytic series, we call it myeloid or granulocytic. If it's the lymphoid series, we call it lymphoid. So then you have acute myeloid leukemia, acute lymphoid leukemia, chronic myeloid leukemia, and chronic lymphoid leukemia. And it's simple to recognize them because in the bone marrow, the acute leukemias have a high percentage, more than 20% of immature cells, or what we call blasts. And then there are certain subtypes that you may hear about, or cousin diseases like the subsets of acute promyelocytic leukemia, core binding factor leukemias, hairy cell leukemia, and I'll touch on these over the course of the talk. But when I came in 1981, none of the chronic leukemias were curable. In fact, in the textbook, they are still called incurable, although I'll show you that they are now highly curable. So in 1981, none of the chronic leukemias, which are about half of the leukemias, were curable. And the cure rate in the acute leukemias in the adults was less than 30%. Fast forward to today, I'm going to show you that I like to divide the leukemias into by the subset of how easy it is to cure them. So I refer to them as the easy leukemias. These are the leukemias where the 10-year survival is now over 70%. So this includes the 3 subsets of acute myeloid leukemia: hairy cell leukemia, acute promyelocytic leukemia, core binding factor leukemia. It includes the 2 chronic leukemias, chronic myeloid and chronic lymphocytic leukemia. And in green are the entities that moved from intermediate to easy leukemias over the past 5 years, as I'll show you. So that includes also the subsets of Philadelphia positive ALL and younger ALL. The intermediate leukemias are the ones where we can cure at a rate of about 50 to 70%. These are older patients with acute lymphoid leukemia, the younger patients with AML, and on the right side are the leukemias which are still difficult. Now, they look like they occupy a small space, but in fact, they constitute a big majority of the patients with acute myeloid leukemia. I'll show you that the historical survival was under 30%. Today, we can show that the 5-year survival is 50% or more. So these are the difficult leukemias, but I would say that 80% of the leukemias are now highly curable. We're remaining with about 20% where we need some work. MD Anderson has been at the leading edge of the clinical translational research. So the leukemia program at MD Anderson, which was founded by Dr. Freireich in 1965, has been involved in most of the discoveries in leukemia. We developed the original research with Ara-C and anthracyclines, which are the curative building blocks of acute myeloid leukemia. I imported decitabine into the United States on an investigator IND in 1992, and decitabine today is a standard of care for older AML and for myelodysplastic syndrome. In the past 5 years, we combined the decitabine, which is a hypomethylating agent, with venetoclax, and this is now a new standard of care in the past 2 years. In acute lymphocytic leukemia, we pioneered the hyper-CVAD regimen in 1992, and then we added new things, and I'll show you that the cure rate was under 30% before 1990. It's now up to 70%. In chronic myeloid leukemia, we were involved in the development of all the, what we call the BCR-ABL tyrosine kinase inhibitors, and these 5 or 6 new drugs, which are targeted therapies, can now make all patients with CML live their normal life, and they are all FDA approved. Chronic lymphocytic leukemia is something unique because even today in the textbooks, if you read them, they say chronic lymphocytic leukemia is incurable. In the past 5 years, following understanding of the biology of CLL, we have combined drugs that target the biology, so ibrutinib and venetoclax. And I'll show you that with 2 years of treatment, I think most of the patients will be cured. And our group has been involved and also, in fact, responsible for the development of over 30 drugs in leukemia. So here I show you the progress. So hairy cell leukemia, which I'll discuss in a second, is curable today at a rate of 90% with a very simple regimen of 5 days of cladribine and then 8 doses of rituximab. Acute promyelocytic leukemia is curable without chemotherapy. With atra and arsenic, the cure rate is 90%, and so on down the line, and I'll go over those. But I want to highlight again that chronic myeloid leukemia, the 10-year survival is 90%. Chronic lymphocytic leukemia, I think the 5-year survival I'll show you is 95%. And in acute lymphocytic leukemia, I'll show you that the cure rate has gone in some subsets up to 80%. Now, it is important also to realize that leukemias are rare and they require intensive treatment and cumulative expertise. So I really do not think that the leukemias should be treated in the community practice. I think they should be referred to cancer centers where there is a minimum threshold of leukemia experts, maybe 5 or 10 that treat the disease. And this is because when you look at large databases, so the first one is on 60,000 patients where the patients were divided according whether they were treated in academic centers or in the community practice. And what you see is that the mortality after 4 weeks of treatment is half of, in academic centers is half of that in the community practice, and the 5-year survival is higher. What you see here is data that the 5-year survival is only 25%. I'll show you that it has gone to about 50%. And then there's another study that was done in 7,000 patients, again looking at NCI-designated cancer centers versus others, and it shows that in the NCI-designated cancer centers, the mortality again is halved from 24 to 12%. And here I show the data in acute myeloid leukemia at our institution, 2 to 5%. That's because we have 40 leukemia doctors, and the average expertise of these leukemia doctors is about 15 years. So expertise matters, and I think leukemia patients should be treated in leukemia centers. Now, here I'm going to start with the easy leukemias. So I'll start with hairy cell leukemia and go down to APL, core binding factor leukemia, the 2 chronic leukemias, and then the 2 subsets of ALL, which have joined recently the club of the easy leukemias. Hairy cell leukemia is a small subset of the chronic lymphoid leukemias. So in the United States, there may be about 3,000 cases a year, not more than that. But we have found that if we use a drug called cladribine for 5 days, followed by a targeted CD20 antibody, rituximab, weekly for 8 weeks, then most of the patients are cured. So I show you here the estimated 10-year survival, it's 90%. In fact, there's not much research done anymore in hairy cell leukemia because it seems to be ideally treated with minimal therapy. So MD Anderson continues to treat the patients on the protocols to report on them 20 years from now to make sure that the data is accurate. Acute promyelocytic leukemia is a subset of acute myeloid leukemia, about 10% of the acute myeloid leukemias. And in 2000, we decided not to treat APL with chemotherapy because there were two targeted therapies, ATRA, which is a vitamin A analog, and arsenic trioxide, which is a poison, that showed that as single agents, they were superior to chemotherapy. So at MD Anderson in 2000, we combined them. And now we show on the left side, the patients under the age of 60. Green is since 2010, so gradually we gained expertise. The blue curve is the cure rate with chemotherapy. It used to be 40% before the year 2000. Green curve is the cure rate since 2010. Almost 95% of the patients are cured. On the left side are the older patients over the age of 60, so still the cure rate is 90%. We lose some of them from older age and others. The third highly easily curable leukemia is what we call core binding factor acute myeloid leukemia. This is about 15% of the subsets of AML. And we recognize them by particular chromosomal abnormalities called inversion 16, inversion in chromosome 16, or a translocation between chromosomes 8 and 21. And here we did not make new discoveries. What we did is we just adjusted all drugs and used them in a better fashion. So fludarabine with high dose RC and a targeted antibody called gemtuzumab, which targets CD33, which is on the surface of the acute myeloid leukemia cells. And here's the data. So before 2000, before we started using the flag with Mylotarg, the cure rate was about 40%. The gold curve is the cure rate since 2010. 80% of the patients are potentially curable. The key is to use this antibody Mylotarg or gemtuzumab ozogamicin that targets CD33. It's very specific in killing those core binding factor leukemia cells. Now, next, I'm going to move to a large subset. So these are the chronic myeloid leukemias. And the chronic myeloid leukemias are driven by a chromosomal abnormality that we call the Philadelphia chromosome because it was discovered in Philadelphia. This was the first chromosomal abnormality that was discovered across the leukemias in about 1955. So essentially, the Philadelphia abnormality is a break in the long arms of chromosome 9 and 22. They exchange their chromosome material, and then there's the production of a new gene or a cancer gene, an oncogene that's called the BCR-ABL oncogene, and this is what drives the leukemia. In 2000, Dr. Drucker developed the first targeted therapy against the BCR-ABL cancer gene. It was called imatinib. And since then, the course of the disease has changed drastically. So if you have treated chronic myeloid leukemia before 2000, like myself, you knew that the disease was invariably fatal with a poor prognosis. The 10-year survival was 10%. The only cure was with allogeneic transplant, and there were no other treatments. Since 2000, since the discovery of imatinib by Dr. Brian Drucker, we developed others, including 5 additional BCR-ABL targeted tyrosine kinase inhibitors. So decitabine, nilotinib, bosutinib was FDA approved about 3 years ago. Asciminib was approved only about 2 months ago. So we have 6 BCR-ABL kinase inhibitors. And with those 6, I think we can functionally get all patients with CML to live their normal life. And I'll show you that about half of them today can stop the therapy and they are curable. So the approved TKIs are shown on the left side: imatinib, nilotinib, decitabine, ponatinib, bosutinib, asciminib. There's one that was developed in Korea, and then there's omacitaxine, which is not a BCR-ABL kinase inhibitor. On the right side are some new ones, and I'm very excited about this one from China. And we started doing these studies here in the United States. It's as effective as the most powerful one, ponatinib, but without the toxicities, I think. So on this slide, I show how the survival improves. So people who are not familiar with survival curves, on the bottom, the horizontal curve is the number of years, and on the vertical curve is the proportion, the percent of patients who are alive. So what you see is that before 1980, the yellow curve, the average survival was about 3 years, and most of the patients were dead by 10 years. Fast forward to today, so since 2000, the yellow curve is the survival of patients if you count the patients who die from chronic myeloid leukemia. So in fact, the estimated 5 to 10-year survival is close to 95%. If you include deaths from transplant, it's 92%. So wonderful data where a person with CML today is told the bad situation, but they are told that we can cure the disease. And I showed already that there are new drugs that we're investigating. Now, the question is, should patients with CML take the drugs for their lifetime? And what we found also that, in fact, if the patients achieve what's called a deep molecular response, meaning they reduce the disease to less than 1 in 10,000 cells, so what we call a PCR of less than 0.01%, and you continue to be in a deep molecular response for 2 years and you stop, then half of the patients will not need any more therapy. So the cure rate is close to 50%. At MD Anderson, we found that if we continue for a deep, durable molecular response for 5 years or more, then the cure rate goes to 85%. And this is what we're doing today at MD Anderson. We give them the TKIs, we induce them into a deep molecular response, so a disease burden of less than 1 in 10,000. For 5 years, we stop 85% of the patients who achieve this are curable. Now we go to the next chronic leukemia, chronic lymphocytic leukemia, and this is again a big number of patients. So chronic lymphocytic leukemia affects about 30,000 individuals in the United States every year. So in 1980, when I came, the only treatments were with chlorambucil and then with some steroids and with cyclophosphamide. In the 1990s, Dr. Michael Keating from our institution discovered the activity of fludarabine. He combined fludarabine with cyclophosphamide and then with rituximab, which is a CD20 antibody. And he developed the FCR regimen, which gave very good results. But the big breakthrough came in 2014, where after deciphering the pathophysiology of chronic lymphocytic leukemia, we developed Bruton tyrosine kinase inhibitors like ibrutinib. We developed venetoclax, which enhances the killing of the leukemia cells, what we call BCL2 inhibitors. And then we combined one of the Bruton tyrosine kinase inhibitors with venetoclax, so ibrutinib with venetoclax. And voila, we found that with a finite duration of treatment for 2 years, you can potentially cure chronic lymphocytic leukemia. This has not yet penetrated into either the oncology practice or the community practice. So this shows you that understanding the signaling pathways in chronic lymphocytic leukemia, understanding the B-cell receptor kinase activity with the Bruton tyrosine kinase, we developed BTK inhibitors, and then understanding that BCL2 prolong the lives of the CLL cells, we developed ABT199, which was later named venetoclax, and we combined these two. So today, there is a curative regimen for chronic lymphocytic leukemia. If you combine a Bruton tyrosine kinase inhibitor like ibrutinib or the better ones, I think there are better ones like acalabrutinib and pirtobrutinib. If you combine this with venetoclax, we think that we can cure the disease. Whether we need the addition of the CD20 antibodies or not is a matter of discussion in the leukemia community. But here I'm going to show you the data in the first 80 patients that we first published in the New England Journal of Medicine, and we updated this in JAMA Oncology 6 months ago. So if you give ibrutinib and venetoclax to newly diagnosed patients with chronic lymphocytic leukemia, which are high risk, so treatment naive, high risk chronic lymphocytic leukemia, almost all of them achieve eradication of the disease, a complete molecular response. And on the left side is the survivor. So what you see is a 4-year survival of 95%. And these patients received the treatment for 2 years and they stopped, and the patients are not relapsing clinically so far. So this shows you the update of the survival curves as we published them recently in JAMA Oncology. And we have a little bit of a longer follow-up, but again, it shows you, and now we have 120 patients, it shows you that this couplet therapy is potentially curable in over 90% of the patients. So I think the future of CLL therapy is going to be with probably the best Bruton tyrosine kinase inhibitor, probably pirtobrutinib or acalabrutinib, with the addition of venetoclax. Now I'm going to discuss the 2 new easy leukemias, and these are subsets of ALL, Philadelphia positive acute lymphocytic leukemia, and patients with ALL who are under the age of 60. So if you look at patients with ALL under the age of 12, they are highly curable. 90% or 80% are cured. They are cured at the expense of needing 15 chemotherapy drugs given for 3 years in an intensive fashion. So many of those children who are cured have the burden of the complications of that chemotherapy and the burden of needing chemotherapy for 3 years. When we do this in the older patients, so patients over the age of 16, what you see is in up to 1990, the cure rate was 20%. In 2000, we started introducing rituximab, a targeted CD20 antibody. In 2010, we discovered 2 new antibodies targeting CD19 and CD22. We incorporated them into the treatment, and the cure rate has gone up to about 60%. So what is the reason for the success? And I think today we have the tools to potentially cure adult ALL at a rate similar to childhood ALL with much less chemotherapy, but using the cocktails of those targeted antibodies that target the signals on the surface of the leukemia cells, CD19, CD20, and CD22. So the success has been because in Philadelphia positive ALL, as of 2 years ago, we are treating the patients without chemotherapy with ponatinib, which is a BCR-ABL kinase inhibitor that I showed you is effective in chronic myeloid leukemia. And instead of the chemotherapy, we started using a CD19 antibody called blinatumomab. So without chemotherapy, this Philadelphia positive ALL that used to be the most refractory and most fatal of the leukemias has become the most sensitive and the most curable of the leukemias, and I think without chemotherapy. In 2000, we added rituximab to the hyper-CVAD, but the big breakthrough came in 2010 when we developed blinatumomab, which we call a CD19 bispecific T-cell engager, or a BiTE, and the antibody drug conjugate CD22, and we combined them with chemotherapy, and we started using them in the front line. Now, you may be familiar with the CAR T-cell therapy. This is another big breakthrough where you engineer the T-cells from the patient to expand into the patient, to recognize the leukemia cells and to kill them. This is a very important breakthrough in salvage ALL, but I think we should move it into the frontline therapy in the setting of minimal residual disease after chemotherapy and the targeted therapies in order to avoid the transplant and cure the leukemias. So let me show you some of the data. So this is before 2000, before we introduced the BCR-ABL kinase inhibitors that we discovered in chronic myeloid leukemia, before introducing them into the treatment of Philadelphia positive ALL. So before 2000, the patients either died on chemotherapy, or if they had a donor, the cure rate was maybe 35% with transplant. Fast forward to today, since 2010, we have used the hyper-CVAD with ponatinib. What you see is the estimated survival has gone down to up to 70%. So this is the regimen, 8 courses of hyper-CVAD. With ponatinib, we do 12 intrathecals, and here you see the first 90 patients treated. Almost everybody achieves the complete remission. Almost everybody achieves the complete molecular response. We do not do transplant except in the patients, in those 15% of the patients who don't respond well. And what you see now is an estimated 7 to 8 year survival of 75%. Now, having said this is so great, I'm going to go next and say this is already old therapy in my book, because we know that blinatumomab is better than chemotherapy. So 2 years ago, we started combining ponatinib with blinatumomab, and we just reported at this ASH meeting last month that if we give that combination without any chemotherapy of ponatinib blinatumomab, almost all patients achieve a complete remission. And in red are the newly diagnosed patients. Look at the 2 year survival, over 90%. Amazing potential cure without chemotherapy and without transplant. So we're looking for these patients to expand the numbers to 100 in order for people to believe the data once we publish them. So if you know of patients who have Philadelphia positive ALL, consider this treatment approach without chemotherapy and without transplantation. Now, as I mentioned, in 2000, we discovered 2 new antibodies that target CD19, blinatumomab, and CD22, inotuzumab. Then we developed randomized trials comparing blinatumomab to standard of care chemotherapy in the setting of patients with refractory relapse ALL and inotuzumab to standard of care. We found that both blinatumomab and inotuzumab were superior to combination intensive chemotherapy. They more than doubled the CR rate, and they improved the survival, but only modestly. So we said, well, these are very expensive drugs. We do not want to use them as single agent in the salvage setting. So we moved them very quickly into the frontline setting with chemotherapy. And I'm going to show you the latest regimen, which we already have improved upon. So this is hyper-CVAD. And for people who treat leukemia, you notice 3 things. The chemotherapy is now not 8 courses, it's only 4 courses. Then we sequence this with the CD19 bispecific T-cell engager. This is in orange. And then the third thing is the maintenance. Instead of 3 years, it's down to 1 year. So we again published at this last ASH meeting the results in the first 38 patients. The CR rate with this regimen is 100%. MRD negativity, elimination of the disease when we look at 10,000 cells, is 97%. It's well tolerated, 2 months mortality negative. And look at now the estimated 4 year survival. It is 80%, almost as high as the estimated survival in children with ALL without the 3 years of the intensive chemotherapy. And this is before we added the inotuzumab and before we used the CAR T cells in the setting of minimal residual disease in these patients. So we can do even better. Now we move to the 2 intermediate leukemias. So these are the leukemias where the cure rate is about 50%. So these are patients with ALL who are over the age of 60 and patients with AML who are under the age of 60. So let's first look at the older ALL. Again, in 2010, we introduced inotuzumab and blinatumomab to minimal chemotherapy, what we call the mini CVD. And what you see is very quickly, we improved the 5 year survival rate from 20 to 50%. And we have now new tools where we think the survival rate is going to go over 60 to 70%, even in the older patients, by adding what we call CD20 bispecific T-cell engagers. And this is the comparison of the mini CVD in Oblina to our own experience with the hyper-CVAD before 2010 to demonstrate that actually when we do without the matching of the patients or with the matching of the patients, that we double the 5 year survival. Now people say, well, you haven't done randomized studies. It is true. We have not done randomized studies, but we do not have the optimal regimens yet to do the randomized studies. I'd like to continue with single arm trials until we have a better regimen that cures maybe 70% of the patients before we do some randomized study if needed or if indicated. Now, acute myeloid leukemia has been the most difficult of the leukemias. And this is a bit ironic because in the 1970s, the Arasi and daunorubicin were the first combination that started curing this disease at a rate of 30%. So people thought, well, this is the paradigm of how all the cancers are going to be cured. But unfortunately, over the next 50 years, little happened in acute myeloid leukemia research until very recently, until we deciphered again the mutational landscape of AML, and we found that 90% of the patients have mutations that we can target in many cases. So a third of the patients have FLT3 mutations, and now we have several FLT3 inhibitors that we add to chemotherapy. About 20% of the patients have IDH2 or IDH1 mutation, and now we have IDH inhibitors that we can add to the chemotherapy. So I'm going to show you what was and what is today, but it is said that what was still prevails today because there hasn't been a good penetration of the discoveries into the frontline therapy of acute myeloid leukemia. So because of the deciphering of the pathophysiology of AML since 2017, we were able to get the FDA to approve 10 drugs for acute myeloid leukemia. So the top two are two FLT3 inhibitors. Gilteritinib is a very powerful one. The next two are the IDH inhibitors. Ivosidenib targets IDH1 mutations, and axitinib targets IDH2 mutations. So these were approved. Venetoclax is a very important backbone of chemotherapy, of targeted therapy. So this is the same drug I mentioned for chronic lymphocytic leukemia, the BCL2 inhibitor. It turns out that it is also a very powerful targeted therapy in acute myeloid leukemia. And then we developed oral hypomethylating agents, which are very useful in older patients with ALL. So let's talk about what was the old standard, which still 90% of the leukemia experts believe in, is what we call 3+7, 3 days of an anthracycline, 7 days of Ara-C. Then you give Ara-C in a high dose. You transplant the patients you can transplant. The others receive more intensification without any maintenance. And if you do this for the patients who tolerate the intensive chemotherapy, in patients under the age of 60, the cure rate at best is 35%. In patients over the age of 60, which are 60% of the patients, in patients over the age of 60, even when you give the intensive chemotherapy, the average survival is less than a year. The cure rate is 10%. So a very bad picture. And I think today we have better intensive chemotherapies than 3+7 for the younger patients, and better therapies than 3+7 in the older patients in the form of low intensity targeted therapy. So let me show you the data. So at MD Anderson, we pioneered better intensive chemotherapy, adding fludarabine to Ara-C and idarubicin, and then recently adding venetoclax or targeted therapy like the FLT3 inhibitors. Once the patients are in remission, we still take them to transplant. Otherwise, they receive 6 cycles of intensive chemotherapy, and then we give them maintenance for 2 years if they are not eligible for the allogeneic transplant. And here's the data. In the first, now we have about 80 patients on different regimens, but I'm showing you the update in 41 patients treated with FLAG-IDA venetoclax. The marrow CR rate is 98%. The 2-year survival is not 35 or 40%. It's close to 70%. And here I compare the intensive chemotherapy with venetoclax to the intensive chemotherapy with the FLAG-IDA. And I showed that comparing apples to apples, but these are not randomized studies, these are sequential studies. We show that the event-free survival and the survival are better. And what you see here now is with the addition of venetoclax, we expect that over half of the patients hopefully will be potentially curable. Now, other people are doing the same, but they are combining the targeted therapies with 3+7. So this is in patients who are FLT3 mutated. Dr. Prats and colleagues added gilteritinib, a FLT3 inhibitor, to 3+7. They showed again a high CR rate, 80%, and the 2-year survival now, which is up to 70%. So we're far from the potential 3-year survival of 35% that I showed you originally with the 3+7. And this is another experience with 3+7, to which are added the IDH inhibitors in the 20% of the patients who are either IDH1 or IDH2 mutated. Again, a CR rate of 80 to 90% and the potential 2-year survival of 60 to 70%. Very positive data, and I think we can do better than that. Now I'm going to finally tackle the difficult leukemias. So these are patients who are older, over the age of 60 with acute myeloid leukemia. So I showed you that historically their average survival was 9 months and 10% were curable. So in 2015, we developed a regimen with azacitidine with the addition of venetoclax. We compared this to azacitidine, which was the standard of care, and we showed that the addition of venetoclax improved the 2-year survival rate from 20% to close to 40%, but still the data is not that great. So we said we can do better than azacitidine. So this is where we reverted to some old experience with low-intensity therapy with cladribine, low-dose Ara-C alternating with azacitidine, and we added the venetoclax to this regimen. And this is very new data. We have not yet published on this in a peer-reviewed journal, but we updated this recently at the ASH meeting. So we've treated now close to about 70 patients, but this is the data in the first 55 patients. The marrow CR rate, better than intensive chemotherapy, 93%. MRD negativity, 84%. Estimated 2-year survival, 60%, not 40%. And among the patients that we can still take to transplant, the 2-year survival is over 80%, and the others who cannot go to transplant is still 50%. So we have made significant progress. And this is the curve showing in blue the patients with newly diagnosed older patients with AML who are not able to receive intensive chemotherapy. The orange curve are the therapy-related or secondary. So in the newly diagnosed, actually the estimated 2-year survival is close to 70%.